Biceps brachii. The biceps brachii muscle is innervated by the musculocutaneous nerve and consists of a long head and a short head. The long head originates from the supraglandular notch and the superior glandular labrum, and the short head originates from the coracoid process as a tendon conjoined with the coracobrachialis muscle. The long head passes through the glenohumeral joint to travel through the bicipital groove to the anterior of the upper arm, and then attached to the proximal superficial of the radial tuberosity, while the short head attached to the distal deep portion of the radial tuberosity. The long head and the short head of the biceps brachii are both responsible for the supination of the forearm, flexion of the elbow joint, and the flexion of the shoulder joint. Among these, the short head is responsible for the adduction function of the shoulder joint, and the long head is also responsible for the abduction function of the shoulder joint. In 2012, Rascher recommended ultrasound examination of the biceps brachii muscle divided into several compartments because various lesions may occur due to the locational and the morphological characteristics of the biceps brachii. It is recommended to examine the tendon of the long head of biceps brachii from the proximal to distal in the following order: origin, intra-articular, rotator cuff interval, proximal part of the bicipital groove, proximal musculotendinous junction. Origin. With the shoulder joint hyperextended and externally rotated, the origin of the long head of biceps brachii can be clearly observed along the long axis by the place in the probe directly below the clavicle and parallel to the clavicle. A rupture at the origin of the biceps brachii or part of the slab lesion can be observed. This is glenoid, humeral head, biceps brachii, origin area. Intra-articular. When the shoulder joint is hyperextended and externally rotated, the biceps brachii muscle becomes tense, and the biceps brachii long head tendon comes into close contact with the humeral head articular cartilage within the glenohumeral joint. The biceps brachii long head tendon can be observed on the articular cartilage. The normal thickness of the long head of the biceps brachii tendon on ultrasound imaging should be less than 2.5 millimeters. If it exceeds 2.5 millimeters, tendinopathy may be suspected. This is the long head tendon of the biceps brachii. Rotator cuff interval. When the shoulder joint is maintained in the hyperextension position but not rotation, and the fluid is moved distally, the rotator cuff interval area is observed. There the subscapularis tendon, coracohumeral ligament, superior glenohumeral ligament, long head tendon of biceps brachii, and supraspinous tendon can be observed. If the thickening of the coracohumeral ligament increases the blood vessel and the colloidal images, and abnormal displacement of the biceps brachii tendon are observed, a pathological condition may be suspected. Long head tendon of biceps brachii, coracohumeral ligament, superior glenohumeral ligament, subscapularis tendon, supraspinatus tendon, proximal part of the bicipital groove. If the shoulder joint is maintained in the hyperextended position and the fluid is moved more distally along the long head of the biceps brachii tendon, a triangular-shaped hypoechoic area can be observed. This is because there is a connective tissue formed between the lesser tuberosity and the long head of tendon of the biceps brachii muscle in the proximal part of the bicipital groove. In case of subluxation, dislocation, and instability of the long head of the biceps brachii tendon, it can be observed that the long head tendon of biceps brachii is moved to the medial side to the lesser tuberosity. Bicipital groove. In the bicipital groove, the long head tendon of the biceps brachii, located deep in the transverse humeral ligament, must be carefully observed. It is important to check whether the margin of the biceps brachii tendon is irregular, whether the content of the biceps brachii tendon is homogeneous or heterogeneous, and whether there is a fluid retention around the long head tendon of the biceps brachii. If the body fluid observed less than 1 millimeter is measured by ultrasound imaging, it is considered normal. Fluid retention within the biceps brachii tendon sheath is often observed directly inferior to the bicep groove. This is because rupture of the long head of the biceps brachii tendon, tenosynovitis of the biceps brachii tendon, or effusion within the shoulder joint accumulated below the bicep groove due to the influence of the gravity. Proximal musculotendinous junction. Advanced to prove more distally and check the proximal musculotendinous junction of the biceps brachii. Since rupture often occurs at the proximal musculotendinous junction, this location must be examined. First, check the long head tendon of the biceps brachii from the proximal part to the distal part along the short axis, then check the long axis. It is important to observe within the joint to the proximal musculotendinous junction. There are two ways to check the long axis of the long head of a biceps brachii tendon. First, after checking the short axis, rotate to prove 90 degrees to check the long axis. The second method is confirm the long axis using the shape of the lesser tuberosity and the bicep groove. The latter method identifies the lesser tuberosity, which is observed as a triangle on the medial side of the shoulder joint, and then move the probe to the lateral side. When the triangle shape of the lesser tuberosity disappears and the bicep groove appears, the long axis of the biceps brachii tendon is identified. Precaution when examining the long head of the biceps brachii tendon. Since the long head tendon of the biceps brachii exists in the superficial layer in the proximal part and the deep layer in the distal part, the probe should be placed perpendicular to the tendon rather than the skin to prevent anisotrophy. This is very important not only for longitudinal view but also for transverse view. Therefore, when inspecting the transverse axis, the probe should not be placed horizontally on the floor but should be performed from downward to upward.